Hello everyone, welcome to Mind Academy. So here we are continuing our series on MPT exam question paper solution. So this is the question paper that came for JAMIA MILIA ISLAMIA in 2022. Okay, we already have posted around three sets of videos. You can go through them, and this is our fourth video. So let's start. So first we'll go through is question number 31. Okay. So myositis ossificans is most common around the joint. Means it is most common around which joint? Option A, knee joint. Option B, hip joint. Option C, elbow joint. And option D, wrist joint. Okay. So first we'll see what is the ossificans or myositis ossificans. Okay. The presence now definition. Presence of bone formation or ossification at a place where it should not be present is that is using the soft tissues is known as hypertrophic ossificans. Okay, so we are learning about ossificans. Okay, so what is ossificans? Ossification means the bone formation. Okay, at a place where it should not be present. So pathophysiology, the BMP bone morphology proteins, okay, BMP, that stands for bone morphogenetic proteins, stimulate primitive stem cells in soft tissue to form osteoblasts. Okay, osteoblasts are formed. Then there is organization of hematoma, then fibroblastic hyperplasia, and then we have osteoid formation. Now, types, basically, there are two types, non-hereditary myositis ossificans, then myositis ossificans progressiva, that is fibrodysplasia ossificans progressive. Okay, then treatment, rest and observation, activity modification, physical therapy to maintain the active range of motion. So keep this in mind that no passive range of motion that may stimulate ossificans reaction and lead to recurrence. So no passive range of motion is done. Why? Because it may stimulate ossification reaction and lead to recurrence. Okay. Next, limb should be rested with the knee in extension, elbow 90 degree of flexion until the focal reaction subsided. Then avoid heat and massage. Okay. Then prophylaxis, that is NSAIDs and low dose radiation can be used. Now, the most common site of HO or hypertrophic ossificans formation at the elbow region and thigh. In elbow, HO most often develops in the brachialis muscle or joint capsule as a result of trauma. Example, comminuted fracture of radial head, supracondylar fracture, and humerus and a tear of brachialis muscle. Okay, so the answer for this question will be answer C. So myositis ossificans is most common around elbow joint. That is option C. So next we'll move to our next question. That is question number 32. Earliest sign of Walkman's ischemic contracture is a pain. Option B, numbness. Option C, paresthesia. And option D, pallor. So first we'll see what is Walkman ischemic contracture. Definition. A Walkman ischemic contracture refers to a complex and variable flexion deformity involving distal limb, typically the wrist and fingers, resulting from the fibrosis and contracture of flexor muscles. Okay, this is Walkman's ischemic contracture. What happens here? There is a complex and variable flexion deformity involving the distal limb, typically wrist and fingers, which is caused from results from fibrosis and contracture of flexor muscles. Now, fracture of hinge joint, example elbow or arm, outcomes this contracture. It is associated with supracondyle fracture of the humerus classically. Okay, now we'll go for pathology. It is caused by ischemic injuries to the deep tissue enclosed in tight, unyielding osteophyseal compartments, often secondary to neglected acute compartment syndrome or arterial emboli that are causing ischemia to the forearm. Then clinical features. A number of deformity can occur in upper extremity. This includes elbow flexion, forearm pronation, wrist flexion, thumb flexion, and adduction, distal metacarpophalangeal joint extension, and interphalangeal joint flexion. The affected limb may become dysfunctional, painful, and may lose sensitivity. Then treatment and prognosis. Therapy depends upon extent of contracture. That is, mild cases are treated with physical therapy, tendon lengthening, and dynamic splinting. Then moderate contracture requires neurolysis and extensor tendon transfer surgeries. And the severe cases are dealt with by radical debridement of scar followed by tendon transfer procedure. Now, the early and the most important sign to detect Bachmann's ischemia is severe pain in forearm and the child is unable to move the fingers fully. So as you can see, the most important sign is pain. So there are 5 P's. First, pain, allow, pulselessness, paresthesia, and paralysis. So answer to this question will be answer A. So the earliest sign of Bachmann's ischemic contracture is option A, pain. Next, we'll move to our question number 33. That is, vector is a physical force that has option A, magnitude, option B, direction, option C, magnitude and direction both, and option D, fixed point of application of force. So first we'll see what is scalar quantity and what is a vector quantity. As you can see in this figure, scalar quantity is a quantity that has only magnitude. Okay, scalar quantity only has magnitude. Then vector quantity is a quantity that has both magnitude and a direction. Fine. So through this line only we can detect that vector quantity has both magnitude and a direction. So answer will be answer B. So vector is a physical force that has both magnitude and direction. Okay. Here it's written B, but answer will be C. We'll just correct it. Okay, so answer will be option C. So I'll just cancel it so that you don't get confused. Sometimes it happens with us. Okay. Fine. So answer for this question, vector quantity has both a magnitude and a direction. Okay, so it will be option C. Next, we'll move to question number 34. That is the second order lever is that which has weight in middle, fulcrum and effort point are either end. Option B, fulcrum is in the middle, weight and effort point are on the either end. Then in option C, effort is in the middle, weight and fulcrum are on the other end. And option D, none of the above. So about lever in detail, I have already done a video. okay, on the basics mechanics that you can follow in our channel. So we'll see directly talk about the second order lever. As you can see in the figure, in second order lever, you can see this is the fulcrum, okay? This is the effort and resistance. So resistance or weight is in between effort and fulcrum. So when you mark a distance from effort and fulcrum, it will be known as effort arm. And when you mark a distance from the resistance of weight to fulcrum, it will call resistance arm or weight arm. Okay, since here effort arm is greater than the weight arm, it will always have an mechanical advantage of greater than 1. Okay, so here you can see in a normal example will be wheelbarrow, and in body standing on the toe, where the toes form the fulcrum, the tender tendon is the effort, and body weight passing through the middle part is called weight. Fine. So answer for this question will be weight is in the middle fulcrum and effort point are at the other end. Okay. So the second order lever, the weight is in the middle. That's it. Simple. Let's move to our next question. Which of the following muscles are stance phase muscles? Option A, quadriceps. Option B, hamstring muscle. Option C, tibialis anterior. And option D, all of the above. Regarding the gait cycle, I have discussed in detail in the previous video. You can check it in our YouTube channel. So we'll see. These are the small tables that you can follow. So if you see in stance phase, in hip stance phase, we have erector spinae muscle, gluteus maximus, hamstring, gluteus maximus at beginning, then activity seizures, and then we have erector spinal muscle, gluteus maximus, hamstring, iliopsoas, rectum magnus, rector longus. Then in knee, we have quadriceps. Then we have quadriceps here. And if you go to ankle and foot, we have tibialis anterior, gastrocnemius soleus, and then peroneus brevis, peroneus longus, flexor hallucis longus. Okay, so as we saw in the table, quadriceps, tibialis anterior, and hamstring muscles are the muscles of stance phase. So answer will be option D, all of the above. Fine. Next, move to question number 36, which is which type of contraction occurs when the force of muscle is less than resistance? Option A, concentric. Option B, eccentric. Option C, isometric. And option D, isokinetic. So normally there are 3 kinds of contraction. Okay. Isometric, concentric, eccentric. In isometric, you see no movement will be there. Muscle contact, but no shortening or change in length is there. Isometric means length will be same. Now, if you go in concentric, the movement will be towards the insertion point, okay? Towards the insertion point. And eccentric, movement will be away from the origin. In concentric, the movement will be towards the origin, and in eccentric, it will be outside the origin. Okay. See, the movement is outside. Here, the origin point is the outside. Okay. So, if muscle force is equal to resistance, it will be isometric. If muscle force is greater than the resistance, it will be concentric. But if muscle force is less than the resistance, it will be eccentric contraction. So, as per our question, the answer will be option B. Okay, that is eccentric contraction. Since the force of muscle is less than the resistance, so the resistance will push the arm downwards. Okay, so it is eccentric contraction. That is option B. Okay. Next, we'll move to question number 37. The question number 37 is the glenohumeral joint capsule is slack. Option A, anterior inferiorly. Option B, posteriorly. Option C, superiorly laterally. And option D, none of the above. So first, we'll see about the basic anatomy of the GH joint capsule. The GH joint capsule is surrounded by a large, loose capsule. Okay, the capsule's inner wall is lined by a synovial membrane. Fine. The capsule is taut superiorly and slack anteriorly and inferiorly, with the arm dependent on side. When the arm is on side, the slack will be anteriorly and inferiorly. The capsule tightens when the humerus is abducted and laterally rotated. Okay, when you abduct and laterally rotate humerus, capsule tightens, making this close packed position for GH joint. So this might also be question in exam. Which of the following is the close packed position of GH joint? That is, humerus abducted and lateral rotated. The capsular surface area is twice that of humeral head and more than 2.5 centimeters of the distraction of the head from the glenoid fossa is possible in the loose packed position. So answer for this question is in this line. The capsule is taut superiorly and slack anteriorly and inferiorly. Okay, so answer is option A. The glenohumeral joint capsule is slack anteriorly and inferiorly. Next, we'll move to question number 38. Which movement of the shoulder gets restricted when supraspinatus is torn? So option A, flexion, option B, adduction, option C, abduction, and option D, rotation. So first we'll see the origin, insertion, and function of supraspinatus. As you can see in the figure, origin is supraspinous fossa of scapula, insertion is greater tubercle of humerus, and action, it abducts the arm. Okay, here you can also see abduction is done by supraspinatus, that is 0 to 5 degree. Okay, and if you see another flexion, supraspinatus is not involved. Extension, not involved. Adduction, not involved. Medial rotation, not involved. Lateral rotation, not involved. So only one movement is there, and that is abduction. So answer for the question number 38, which is which movement of the shoulder gets restricted when supraspinatus is torn, will be option C, abduction. Okay. Sometimes we get confused between abduction and adduction. So better I call it abduction and then adduction. It's easy to remember and less confusing. And here also we have one more slide dedicated on supraspinatus. Okay. Unlike other rotator cuff, supraspinatus has a superior translatory component rather than the inferior translatory component. Given its line of pull, the supraspinatus is not able to offset an upward dislocating action of deltoid, but supraspinatus is still an effective stabilizer. So supraspinatus is a stabilizer. Okay. So with a concentric contraction of supraspinatus, effects offset by the oppositely directed gravitational force. Okay, that results in translatory equilibrium but effective rotation. So the resultant of the gravitational and supraspinous force vectors contribute to an inferior gliding of the humeral head surface during abduction of the arm. So we'll move to our next question, that is question number 39. Okay. So the question number 39 is recurrent dislocation is least common in. Just always read the question like 2 times, 3 times, okay? Because if you read it wrong, you might answer it wrong. Because it's asking least common. Okay? Option A is shoulder, option B knee, option C patella, option D none. Okay? It's asking least common. As we all know, most common is shoulder. Okay? Then patella also get dislocated. In lower limits, the most common will be patella. Upper limb, shoulder. Then left is knee. Since it is guarded by all the muscles and ligaments, so it is least common. Recurrent dislocation of knee is least common. Okay. So first we'll discuss about shoulder joint. Shoulder joint, the commonest joint in human body to dislocate. Head of humerus is not stable in glenoid. Okay, since head is not stable, here muscles attachment is there, but here it's quite unstable. So it's easy to dislocate. And patella usually dislocates laterally. It will dislocate laterally. Okay. Acute dislocation from sudden contraction of quadriceps. If there is a sudden contraction of quadriceps, there will be an acute dislocation. Then recurrent dislocation due to laxity and habitual dislocation from underlying defects in childhood. Now, knee dislocation, it is the rarest and most serious injury. Okay, knee is guarded by muscles and all its supporting ligaments, as you can see. So the dislocating knee requires a greater amount of force, which is often associated with other injuries. So the diagram is totally clear. Okay, most common shoulder joint and patella usually dislocates laterally, and least common is knee. So answer is option B, knee joint. Okay. Next, we'll move to the last question of the day. That is question number 40. All of the following are a feature of a CTEV shoe, that is a modification of a normal shoe, except option A, straight inner border, option B, presence of metatarsal bar, option C, outer shoe rise, and option D, none of the above. So first we'll see what is a CTEV shoe. CTEV shoe is a modified shoes for child who start walking. These shoes are used until 5 years of age. Special features are straight inner border, outer shoe raise, and no heel. Okay, so two of the more common features are straight inner border, outer shoe rise, and the third is no heel. But here we can see these two are present. Okay, this is not present. So answer for question number 40 will be option B, that is presence of metatarsal bar. Okay, because here the bar is known as Dennis Brown bar. Okay, which is used to correct the foot and hold them in dorsiflexion, that is foot pointing up, external rotation, that is foot pointing out, and valgus, that is platinum arch. Now you will ask, what is a metatarsal bar used for? Metatarsal bar, it disperses the metatarsal head pressure to metatarsal sac and elevates the metatarsals. Clinical indication: metatarsalgia, plantar plate pathology, forefoot hyperkeratosis, and forefoot ulceration. So presence of metatarsal bar is not there in CTEV shoe. I hope you all learned something from this and it will help you. So if you like our video, do like it, subscribe our channel and share it among your friends. Thank you very much. See you all in the next class. And if you want to see our previous videos, you can go to our channel, or I will place a link in this video at the end. So thank you very much. See you all again in the next video.